Thanks for joining today. I'm going to be talking about SARS-CoV-2, understanding risk factors and how to safely reinvigorate U.S. life and work. My name is Kevin Maki. I'm an adjunct professor at Indiana University School of Public Health. I'm also chief scientist at Midwest Biomedical Research and Great Lakes Clinical Trials in Chicago. And I'm joined by my colleague, Justin Otten, who was very helpful in terms of putting together the slides and is the administrative lead for a study that I'll be talking about that we're just in the process of launching now related to SARS-CoV-2. So what I'll be talking about today is in three parts: risk factors for SARS-CoV-2 transmission, how is it transmitted, where is exposure occurring, how can we reduce spread and keep the workplace safe, and then a little bit about immunity. If you're infected and recover, are you protected against reinfection? And what about vaccines? How effective are they and how long will they protect against infection? And that will lead into a discussion of our study that we've just launched, the Aegis study. And Indiana University is the coordinating center for the study. I'll be talking about the questions we're asking, the study sample, and the funding that we've received to date to address some of these important questions about whether someone who has been infected with SARS-CoV-2 and recovered is protected from reinfection, and if so, to what degree and for how long. So first of all, let's talk about SARS-CoV-2, which is the virus that causes the COVID-19 disease. How is it transmitted? And there's been a lot of debate over the last year about the importance of aerosols versus droplets. And I think that at this point, it's generally accepted that both aerosols and droplets are involved in the transmission. And this is a quote from Penn Medicine from a statement that they put out. Droplets, which are expressed by a person who's speaking or breathing, fall to earth quickly, but aerosols can travel on air currents. And so they're potentially going to hang around for an extended period. And therefore, aerosolized viruses are much more infectious than viruses that are bound only to respiratory droplets. So the flu, as an example, is mainly transmitted through respiratory droplets, and it appears to be less contagious than SARS-CoV-2, which is transmitted by both droplets and aerosols. And so that's going to have important implications for what we can do to help reduce the risk of infection and to keep the home and the workplace safe. So how do we reduce the spread? Well, of course, you've all heard this multiple times. Physical, or sometimes called social distancing, reduces the exposure to respiratory droplets. Wearing masks that cover the nose and mouth helps to reduce the amount of droplet that is coming out and may somewhat reduce the degree of aerosol that is coming out of an infected person. The type of mask is important. N95 respirators are more effective than surgical masks, and they are more effective than cloth masks, but all masks probably have some degree of effectiveness for reducing the amount of aerosol and droplet that is expressed by a person who's infected. Hand washing is important to avoid transfer of droplets to the nose or eyes. Surface disinfection will kill viable virus from respiratory droplets. We don't know exactly how long virus remains viable, but it's probably viable for some period of time, depending on a variety of factors such as atmospheric conditions, the surface, and so forth. So it's important to disinfect surfaces, especially around someone who is known to be infected, because those surfaces may have live virus that is potentially infectious. Avoiding large gatherings and smaller multi-household gatherings is important because we know that most infections are occurring in the household. And so when you have people from outside the household coming in to the home, that is increasing the risk of exposure. And once someone in the home is infected, then there's a much greater likelihood that others in the home will become infected. And then point number 6 is something that I think has received too little attention, and that is controlling air quality. And I'll talk more about how to control air quality in a few minutes, but I think that this is an important element that hasn't been emphasized enough in the media. And of course, That's because we have aerosolization, and so you want to reduce the amount of virus in aerosols that can build up in an enclosed space and potentially infect a person who is breathing in those aerosolized viral particles. So where are exposures occurring? Well, this is a slide from Governor Cuomo in New York. The state did contact tracing where they contacted individuals who were close contacts of people who were known to be infected. And this is about 46,000 people. And they looked at where is transmission really occurring? What is the most likely point of origin where someone became exposed to the virus and therefore was infected? And 74%, the large majority, was exposure in the household and social gatherings that are in the household. There was some via healthcare delivery in hospitals and doctors' offices and so forth. There was some in higher education among students and employees. There was relatively little, about 1.4% in restaurants and bars. And then there was some related to travel, vacation, and sports, and first responders, police, fire, EMS, and the military. But everything else was less than 1%. So the large majority of exposures seem to be occurring in households and related to small social gatherings. So how do we reduce the transmission in households? And what is the likelihood that if somebody is infected in a household, that another member of the household will be infected? Well, we have an analysis from 54 studies, about 78,000 people. And the results from that analysis suggested that if one person in the household is infected, there's about a 17% chance that someone else in the household will become infected. But that's much, much higher than the risk in the community. So most exposures are being passed from person to person within a household. Exposure or transmission was much more likely if the infected person was symptomatic as compared to asymptomatic, more common for adults as compared to children, and the closer the contact between two individuals in a household, the greater the likelihood of infection. And so for that reason, we see spouses having a much higher risk of infection as compared to other family contacts. Now, what can you do in the home if someone is sick? Well, first of all, anyone who's been exposed should be quarantined for at least 10 days. So people who have a sick family member in the home should be quarantined and not be going out in public for at least 10 days. And then for the sick individual, that person should be isolated, and anyone who tests positive or who has symptoms should be isolated. And then the usual recommendations apply: distancing, masks, hand washing, etc. And then air quality should be controlled. So leave the windows open, do things to increase air exchange. Portable fans are helpful in this regard. Humidify the air because more humid air cuts down on aerosolization. Portable air purifiers are very helpful. So I have pictured here one. We happen to have a model just like this in our home in several places. And so this is an air purifier that pulls air in and has UV light, which is germicidal, and it has a HEPA filter. And so that helps to reduce virus that may be aerosolized in the air. And in our clinic in Chicago, in every exam room, we have one of these, and every relatively enclosed space, we have one of these. This model costs about $150. And I think it can be very useful in the home and in the workplace to reduce the likelihood that someone is going to be breathing in aerosolized virus. I'm happy to say that even though our clinic in Chicago has mostly been working on COVID studies for the last number of months, we have had 0 infections among our staff members over that several month period. And that's because we're using personal protective equipment. We're paying attention to air quality. We've increased air circulation. We've installed HEPA filters in the overall air circulation systems, and we're using these portable air purifiers. So it's important also in the home, especially if someone is sick, to avoid currents of air from the ill toward the healthy. So if you're going to use a fan, for instance, next to an open window, the fan should be blowing the air out the window and not circulating it throughout the home. How do we keep the workplace safe? Well, first and foremost, if anyone has symptoms, even mild symptoms, they should stay home and isolate. And of course, this can be problematic when it comes to people of lower socioeconomic status who are very concerned about losing a day of pay. If in doubt, they should stay home, and policies should be in place to encourage employees to stay home when they feel even mildly symptomatic. And ideally, there would be policies that would allow them to do that without financial penalty. Of course, you have to balance the potential for abuse in the system against the risk of bringing someone in who thinks that he or she is having allergy symptoms or a cold, but it turns out to be COVID. And in fact, that's what was seen in studies of healthcare workers who were infected. Many of them did not realize that what they were experiencing was COVID. They, in fact, thought they had allergies or cold symptoms or what have you. I have asthma and allergies, and so every couple of days I think to myself, uh-oh, is this COVID? And then I have to sort of either get tested or figure out if it's COVID before I am going to be around other people that I could potentially infect. So far, so good, no COVID. Make testing available for employees to identify those who are truly positive versus having colds, allergies, etc. Encourage vaccination when it's available. Follow safety procedures, avoid overcrowding, prolonged time in enclosed spaces, require masks, distancing, surface disinfection, pay attention to air quality, etc. And then you want to create a workplace that minimizes the risk of contracting COVID-19. And that's important for productivity and lack of disruption, but it's also important to avoid liability. And so employers really need to take into account what they can do to create a safe work environment for a variety of reasons. Vaccines, this has been, of course, in the news. The first vaccine was approved on December 11th, and the rollout has been a bit slow and messy, but is really picking up now. We've got about 11 million people with a vaccination, at least the first dose. And the two that are currently approved are messenger RNA vaccines. And what they do is they get into cells. They're delivering messenger RNA that gets into the cells of the person who received the vaccine and cause the cells to produce the viral spike protein. And then the body has an immune response to that that includes developing antibodies that help to knock out the virus. So if the person has those antibodies and then is exposed to the virus, the antibodies hopefully will be in sufficient quantity to knock out the virus and prevent the person from developing symptoms. So both of these vaccines are delivered in 2 doses. They've been shown to be very effective, about 94% effective at preventing symptomatic COVID-19. There are some side effects. Anywhere between 15 and 20% of people experience fatigue, headache, muscle pain, chills, kind of flu-like symptoms. Generally, these last 24 to 48 hours. And so while they are somewhat unpleasant, they're certainly much less unpleasant than spending several days in the ICU. There are additional vaccines in development. Adenovirus vaccines from Johnson & Johnson and AstraZeneca may be available soon. There are several others in development as well. So I'm very optimistic that once we get past this cold and flu season, the cold and flu season generally goes from October 15th to April 15th, through a combination of a lot of people already having been infected, a lot of people, especially those who are older and in vulnerable categories, having been vaccinated, and moving into the summer months where there are fewer infections, that things are going to start to return toward normal. Maybe not 2018 kind of normal, but moving toward a more normal situation in terms of the community, workplaces, lack of restrictions, and so forth. Now, that's the good news. What is the reason for concern? I think there are some reasons for concern. Common cold coronaviruses are responsible for about 1/4 of the common colds that occur. There are others, adenoviruses and rhinoviruses, that cause the rest, but about 1/4 are caused by common cold coronaviruses. And we know with these that reinfection can occur. So the top panel there shows reinfections in a follow-up period. So once somebody's had an infection, in this particular case, there were no reinfections for 9 months, but then each dot represents a reinfection among people who were being followed in the study. And so you see that reinfections do occur. Now, we don't know whether that will be the case or not with SARS-CoV-2. There have been some documented reinfections, but relatively few. But if we have protection for 9 months or a year, then we wouldn't be seeing a lot of those yet. So this is a reason for concern. I mentioned seasonality because we know that colds and flus occur in about half the year. 80% or so of the colds and flus occur between October 15th and April 15th. And you see that with common cold coronaviruses, where you have fewer infections during the summer, many more infections during the winter months. That relates in part to weather and sunshine and people spending time indoors and humidity, and then other factors that we don't understand fully. But there is a seasonality, and we're certainly seeing many more infections now for SARS-CoV-2 than we did over the summer months. And so it appears to be following that same pattern. So I mentioned antibodies. One part of the immune response, not the only part of the immune response that is important, but one portion of the immune response is developing antibodies, and these antibodies recognize the virus that the person has had, and they work to bind the virus and keep it from infecting cells. And so what we see in SARS-CoV-2 is that many people who are infected develop antibodies, not everyone. But among those who develop antibodies, there is a significant decline in antibody levels over time. Now, whether that means that people are losing protection or not, we're uncertain. Now, there are memory cells that circulate, and it could be that if somebody has been exposed previously and they're exposed again, that the memory cells kick in and start producing a lot more antibodies with a new exposure. But we just don't know at this point the degree of protection and the length of protection someone has several months after having been infected with SARS-CoV-2. And so that brings us to a study that we have just launched called the AEGIS study. The School of Public Health at Indiana University in Bloomington is coordinating the study. And Aegis was the shield carried by Zeus and Athena, featuring the head of Gorgon in the Iliad. And so this image here shows the Aegis shield. And so we're really asking the question, how much of a shield does a person have after being infected with SARS-CoV-2 and then recovering from that infection? So the questions we're asking are, if you've been infected and recovered, are you protected against reinfection? If so, what is the magnitude of that protection? Because people like to think of immunity as being like an on-off switch, but it's not really like an on-off switch. It's more like a dimmer switch. So some people have very strong immune protection. Other people have partial immune protection, and other people may have good immune protection that then wanes over time. So how long does the protection last, and to what degree do you have protection? Does it matter whether you had symptoms or not? In general, people who had more severe COVID-19 seem to have higher antibody levels. And so we really need to understand what kind of protection we have against reinfection if someone's already been infected. And then are there biomarkers that we can measure that will tell us whether a person is still protected? And we also are going to need to know that with regard to vaccines, because at this point, we don't know whether we're going to need a booster shot every year or every other year, or maybe every 5 years. We just don't know at this point. So the first order of business is to get people vaccinated, and then we can start figuring out, well, how long are they protected? And how does the immune response to vaccination compare to the immune response that someone has after they've been infected and recovered. So we recently launched the study at our research clinic in Chicago, Great Lakes Clinical Trials. At our clinic, we do food and drug studies to evaluate food products and pharmaceutical products, including vaccines. And so recently, most of our work has been treatments, vaccines, and diagnostics for SARS-CoV-2, COVID-19. And so I'm, happy to say that there's been a lot of good work that has been done in record time over the last few months. And so we do have good treatments that have been tested. We do have vaccines that seem to be effective. And so I'm very optimistic about the future of this pandemic. And I think we're in the latter innings of the pandemic, but there's still a ways to go, and we still have unanswered questions. In our study, we're going to be recruiting people who have previously been infected and others who have not been infected. And among both of those groups, some will get vaccinated during the study and some will not. So we'll be able to look at how the immune system responds to infection and vaccination, and then how markers of immune function evolve over time, and whether those markers of immune function tell us about a person's degree of protection against infection or reinfection. And so the co-principal investigators are David Allison, the Dean of the School of Public Health, Bloomington, and myself. And then the administrative lead is Justin Otten, who is on the call with me today as one of the moderators. And we have collaborators from various institutions, George Washington, Stanford universities, University of Iowa, NYU, and Harvard, as well as various institutes and private companies, La Jolla Institute for Immunology, Semaphore, which is handling viral testing and genetics, Midwest Biomedical Research, and Great Lakes Clinical Trials, which are the companies that I'm affiliated with, and then the Gordon and Betty Moore Foundation. So we're very pleased. We think this is important research, and grateful to donors. We've so far raised $15 million from private donations through the IU Foundation. Some of the large donors are the Jack Dorsey Start Small Initiative and the Chase and Stephanie Coleman Foundation, as well as others. And we are still trying to raise additional funds in order to support this work. And if anyone is interested in donating or knows someone who may be interested in donating, we encourage you to contact Justin Otten, who's on the call today, and he can put you in touch with people who can facilitate that. And we're accepting both funds as well as in-kind donations of things like shipping and gift cards to use as stipends for study subjects and so forth. Hopefully, with more funds, we'll be able to study a larger number of subjects than the initial 2,100 planned, and include more representation of high-risk subgroups, do some things with viral sequencing, and have a longer follow-up period. But we're off to a good start, and we think that this study is going to answer some very important questions. So what are the take-home messages today? Well, first, SARS-CoV-2 transmission occurs in homes and small gatherings primarily. To prevent transmission, masks that cover the nose and mouth, physical distancing, hand washing, and avoiding gatherings, especially multi-home gatherings or multi-household gatherings in the home. Surface disinfection and attention to air quality are important. Air quality would include increased air exchange, HEPA filters, UV germicidal light in air purifiers, and humidification. And then we have effective vaccines now. They're being rolled out. The two that we have 94% protection against symptomatic SARS-CoV-2. Although questions remain about the degree and duration of immunity after natural infection, as well as the duration of immunity after vaccination. And the Aegis study that we've just launched aims to answer some of those questions and compare natural infection to vaccination. So with that, I will be happy to take questions. And the main topics, of course, are SARS-CoV-2 and COVID-19, vaccines, treatments, immune function, etc. But within reason, I'll be happy to take questions about any non-political topic. Thanks very much for your attention.
Great. Thank you so much, Kevin. We've had a few questions come up in the chat. Hi, I'm Justin Otten, the administrative lead on the study. Donna Berry began with a question. She's also expressed interest in joining the study if possible. I'm not sure if she's located in Chicago, but Donna, if you want to indicate that in the chat. And Kevin, so I guess first question on behalf of Donna, she and her son, college-age son, got infected. Right now they've been quarantining in their cottage. Her question is, when we return home, how long will virus stay in the cottage, like on couches, rugs, etc.? Can we just spray the cottage with Lysol, and should it be fine in a few days? What are your thoughts on how long the actual virus sticks around on fabric?
The answer is we don't have great data, but the data we have suggests not terribly long. This virus has a lipid envelope, and so with a lipid envelope, that gets disrupted pretty easily. And so we don't think that the virus hangs around for long periods of time. And so a few days should be sufficient. On some surfaces, it can remain longer than on other surfaces. Fabrics and so forth, probably it doesn't remain very long, but certain types of very smooth surfaces may be able to host viable virus for a longer period of time. But in general, we're talking about days. So if you look at the policies of various stores and some countries have put out guidance, they're saying essentially, 3 days or so should be enough, that you should not have infectious virus hanging around. So that's the best we know. In terms of getting involved in the study, we would welcome anyone who would like to be involved in the study who's in the Chicago area. That's the only site that's been launched so far. Our clinic is on the north side, 5149 North Ashland, and it's Great Lakes Clinical Trials. And so if you're interested, just Google Great Lakes Clinical Trials, call the main number, and someone will be happy to screen you to determine whether or not you would qualify for the study. We're actively recruiting participants now. Thanks so much.
And I've just inserted my email address so anyone can feel free to email me with, if they're interested in participating or if they've got other questions. And I would add, Donna, that, airing out your cottage would be a great way to also help sort of purge out the old air and get fresh air in and hopefully be done with the virus. Another question comes from Denise Odell. She writes, once the vaccines start getting distributed more widely and restrictions become lifted some, do you see the possibility of mobile testing units set up at events functions to ensure virus-free before entering?
I do, and I'm a little bit disappointed that we haven't had more sort of immediate and highly accurate tests available sooner. So there's something called CRISPR technology that looks promising to be able to provide very accurate results. We do already have some testing that takes about 15 minutes to get a result that looks at antigen, and so it can be done with a nasal swab. Nasal swabs are a lot more pleasant than the nasopharyngeal swab, where they go way back in the nose all the way back to the throat. And so I'm a little bit disappointed that we haven't seen more of these rapid tests that would be used or able to be used in settings like people just about to get on an airplane or people about to go into a concert or some other group setting. So unfortunately, I don't think we're going to have a lot of that available in the next few months. I am optimistic that by the end of this cold and flu season, we're going to be really, by that time in kind of the 9th inning of this. Doesn't mean that the virus will go away, but it means that next year we should be in a much better position in terms of infections. Of course, what we don't know is whether we'll have to get a vaccine every year like we do for influenza. This virus doesn't mutate as quickly as influenza, but there are genetic variants that are popping up that have different properties. Right now, we think the vaccines we have will protect against those genetic variants. So far, we haven't seen any where we don't think the vaccine will protect. So fingers crossed that the vaccine works, it works for a long time, and that we don't have any new strains popping up that, send us back into a more difficult situation.
Before I get to the next question, Kevin, but to continue this thread, I'm curious, I've got a friend who's a social worker, and his son is my son's friend. And so he dropped him off the other day and he said, "Hey, look, I got my first jab." And he showed me the app on his phone, and it says his name, date of birth, and he's got his first Moderna dose. And I wonder, and this, ties to Denise's question of, will people in a way maybe be able to just show that as sort of a, immunity passport that they might show on their phone that they've gotten their vaccines, and in a couple of months, that's sort of a green light and an entry ticket for them? Or is it just conjecture at this point? Is it too early to
Yeah, this is a controversial issue. So a lot of people support the idea of immunity passports, if you will, something on your phone that says, "Look, I've been vaccinated." And I generally support the idea of people being able to show evidence that they've been vaccinated. Having said that, the question really becomes, should it be required? Should you not be able to go to the workplace without showing you've been vaccinated? There are settings like healthcare workers where influenza vaccination is required, with some exceptions for religious objections and so forth. But, we don't know at this point how much that may be the case, where you'll be told you can't fly if you don't have proof of vaccination. You can't go to a university unless you have proof of vaccination and so forth. And so that's the controversial issue, and that's above my pay grade. I'll stick with the scientific issues and let someone else deal with the policy issues.
Great, thank you. Well, and to segue to a more specific question, Sandra Wagner asks, are there any available studies related to quality nutrition and prevention or increase of your immune system to prevent the attack of the virus?
Yes, we do know that nutrition is an important element of the maintenance of the immune system. So there are some things that are being studied that seem to be important. Vitamin D in particular seems to be important. There are a couple of different arms of what is called the adaptive immune system. Antibodies get all of the press, but there's another arm of the adaptive immune system called T cells. And antibodies knock out virus that's in the blood, but what T cells do is they find cells that have been infected and they kill the cells. So you have these things called killer T cells or cytotoxic T cells, and they go after infected cells and knock them out. And one of the reasons that we're seeing much worse outcomes in older people as compared to younger people is that older people, their T cells don't work as well. So there are various nutrients that seem to be associated with more T cell effectiveness, vitamin D being one of them. Zinc is involved in various elements of immune response. And so I'm not going to recommend that people go out and take supplements as an example, but I am going to recommend you eat a healthy diet. For people whose diet isn't that healthy, supplements might be reasonable, but I'm not going to make specific recommendations. But healthy diet, plenty of rest, regular exercise, all of these things will help keep the immune system in good shape so that if you get exposed, then you're likely to have a good immune response, which should limit the degree of illness that you develop. Because again, older people are on average having much worse outcomes, in part because their immune system isn't working as well. It works a bit more slowly. It's not as robust as younger people. And so, most of the deaths in this country from SARS-CoV-2 have been in older people. So about almost half the deaths have been people in nursing homes. And then a large fraction of the remaining deaths have been in people, 65 or 70 and older. Yeah, the comment here that just came up about probiotics, there is good evidence that the gut microbiota have important roles in the immune system. We don't have great studies right now on SARS-CoV-2 with regard to probiotics, but prebiotics, that is dietary fibers, and probiotics may very well be ultimately shown to have a role. Things that are mentioned here in this post, like turmeric and quercetin, There are some suggestive data, vitamin C, et cetera. We don't have great clinical trials right now, but I think that for many of these things, the risk is very low. The benefit is uncertain, but at least theoretically, there could be a benefit. Thanks, everyone, for your attention today, and I wish you all good health, stay healthy, and hope that you'll all consider getting vaccinated. Thanks so much.
Thank you.